watching Cablevision, Channel 31, local origination programming, your hometown network.
Welcome to Mind Over Matter. Pleasure to welcome Darlene Sheehan, who is a substance abuse specialist and a mental health consultant, a psychiatric nurse who's had lots of experience working with adolescents. And today we're going to be talking about adolescents at risk. Maybe we could start by just talking about the problem itself of adolescents at risk. In your opinion and in your experience, how big a problem is it? And I guess we're going to quickly get to sort of how it presents, and later on, of course, we'll talk a little bit about what can we do about it. But how big a problem is it?
Well, in my practice, I have worked. The majority of my work has been in the city, with some peripheral work with adolescents outside the city in the suburbs. And I would say that it's a really big problem compared to, with the drugs and the alcohol, with kids feeling very depressed, unable to function in school. I think it's quite a big problem. Some of the problems that we see when I was working with the children in South Boston was a lot of kids at a younger age, at 8, 9, 10 years old, terrible anxieties, feelings of severe depression, insomnia, and the beginning to use drugs and alcohol, which is a big concern. So I would say that it's quite a significant problem today. Yeah.
Is it getting worse?
In my own personal experience, I feel like it is. And if you look at some of the stats, addiction and types of drugs that the kids are using, and hospitalizations of younger and younger people, it definitely, there's a significant increase with kids with psychiatric and substance abuse problems. And I know, we all grew up in the 70s, and I grew up in the 70s, and drugs and alcohol were there, and but it's different today. The kids today, at a younger age, not only are they using drugs, they're using harder drugs. In South Boston, heroin is the drug of choice for a lot of young people, although alcohol is actually the #1 drug. Still, heroin with a younger and younger population. And hospitalizations, you remember the suicide cluster, we had a significant amount of young people that needed to be hospitalized from Dorchester and South Boston for depression, anxiety, suicide ideation. So it's really scary, it is. And
but you use the word depression first. Is depression coming first, and the drugs kind of self-medication? I know it's a problem unto itself, but does it also reflect a kind of a depression, anxiety cluster that we need to pay attention to?
Well, I think depression, as you know, depression, we all experience depression. I think the difference between a lot of the young people that I have worked with the depression is that they don't know how to get out of it. A lot of the young people that I have worked with have a family history of depression. So to say what came first, the drugs or alcohol, I think the alcohol and drugs are a symptom of an underlying issue, whether it be depression, mental illness, maybe some medical problem that's going on. So, I think it's an underlying issue.
And let's talk about symptoms. I mean, because how adolescents at risk might present, and keeping in mind that our audience is in large part members of the Alliance for the Mentally Ill, for example. What do parents and teachers look for? What are they likely to see that might indicate to them that a kid is at risk?
Well, you know, a lot of if you have a kid in school who is acting out, a lot of the times a young person is acting out in school and he's being branded as a troublemaker, or he's angry, or he's just a bad kid. And what you see is a kid acting out, and that's a kid.
Meaning what? Why don't you define that, Darlene?
Well, acting out meaning, you know, he might have gone through a personality change. Might be just you can't get him to abide by the rules. Is fighting in school, just not paying attention. To me, that is a signpost that there's something going on with them, and I'd pay close attention to that. Someone who maybe isolates himself from others or needs to be the center of attention. It can go from one extreme to another. It's, you know, when I hear somebody, I was up at one of the high schools and, you know, I heard somebody talk about a student who was acting out, and we had professionally worked with the student, and I knew that he had a lot going on at home, was very depressed, had lost a family member to suicide, was not talking about it, but what he was doing is going to school and just completely acting out. And he was, you know, being branded as a bad kid. And to me, that was his way to be able to let people know that the only way he knew to let people know something was going on with him. At home, you might have a child who's just a complete personality change. You know, someone who was outgoing and dressed, you know, really into friends and sports, and now is the exact opposite. Or a kid who's maybe very quiet and depressed. I'd be very concerned about someone like that who was very quiet and depressed, and all of a sudden now is jovial, and just he could be high, or she could be high risk for suicide. You know, has come to a point after going through a period of depression where they've made a decision, you know, and starts giving things away, and you know, starts making amends and say, you know, just complete. Almost like they're going away on a trip, you know, the way that they're acting. And so there's different signposts, and you have to listen to it, and it might not be what you expect, you know. I think people have an idea of what depression is, that they get very quiet, and they just shut down, and they're crying and weepy, and you know, sometimes a lot of the girls that we've worked with have acted that way. The boys tend to act a little differently. They get angry, and not to generalize, some of the girls have acted that way too. They act out. So you have to be really on top of that.
So you're saying, or you're suggesting really, that then kids will typically give themselves away. I mean, they will signal in some way. Maybe they're not as astute as some adults at hiding the fact that they're depressed, troubled?
You know, that's not always the case. I mean, we have had. There was, I believe, 7 suicides in 1 year, if you can correct me if I'm wrong, in South Boston, and you know, I'm sure, and there was many attempts, and out of some of those attempts, the people in their lives who know them very well, their teachers, their family members, mental health workers that were working with them for one reason or another, said there was nothing that they could pick up that they were increasingly depressed or suicidal. So, but I think if looking hindsight, which we all can do, there was something that, you know, maybe that they were doing that we could. Everybody's different. Everybody's individually. We can't generalize that everybody's going to do the same thing if they're suicidal or depressed.
So are you maybe suggesting that it's something that parents can talk to their kids about, or teachers might directly or indirectly ask about of their students?
Yeah. I think people are afraid. I think people have the misconception that if you ask a kid, are you suicidal, that they're going to commit suicide. And
so you'll plant the seed.
You'll plant the seed, and you know, that's definitely not the case. I think if sometimes kids do things because they don't know how to ask for help. They start acting out maybe with drugs. They start acting out they're in trouble with the law or with school. they're screaming for help the only way that they know. And, I know with some of the kids that I've worked with, just saying, just sitting down and talking to them and teaching their parents how to sit down and not being afraid to do that, is what can open up, the conversation, and not being judgmental. I think parents need to be educated, about mental illness. We all need to be. Society needs to be educated about mental illness. It's not a moral issue, that it's a real part of life today. It's part of who we are, the mental part of ourselves. I tell the clients I work with that, when we're depressed and anxious and sad and angry, it's our body's way of saying something's not right, just like when we have a physical pain. It's telling us that something's going on, and it's important that we do something, that we talk about it, we let somebody know. And that's, people think of mental illness and they think of depression, and if they don't know anything about it, they think it's this, they're really afraid of it. And I think that if people talk about, being depressed, that the chances of them ending up in a psychotic stage or ending up suicide will be lessened. If they learn how to talk about what's going on.
Why do you think it's so hard, we've just got a couple minutes left, to draw it out of them, though? I mean, it's kind of like my daughter had a toothache the other day, and she wanted it taken care of right away. I mean, if people are living in agony, why, when they're not letting you, cluing you in easily, why is it so hard with some of the kids for them to share it with you or let you know?
Well, I don't think it's just the kids. I think as a society, it's not an acceptable thing to do. I mean, we all grew up, I grew up in, where you dealt with your problems in your house, and you're not supposed to be a whiner, and I don't think we were educated on that part of ourselves, that we weren't taught how to talk about our emotional. A lot of times we don't know what we're feeling because we haven't been educated, and we weren't taught how to do it.
So it's harder maybe with strangers too. I mean, like when people come to me,
right.
Obviously they're going outside the family and they're talking to a stranger.
Yeah.
Sometimes they think, I'm getting paid for listening to them, so why should they bother?
Yeah, I think it's just, I think the bottom line is just hard to talk about that. Not out of fear, but just not knowing how to do it, and feeling like they're not supposed to do it. And it's on a moral issue to feel depressed or sad.
So you're back to really stigma. Well, look, we're going to take a break, but maybe after the break we could sort of pick up and talk a little bit about why adolescence is such a problem for these kids. What's going on that they end up so troubled. And so perhaps after the break we'll start with that.
Sounds good.
Thank you.
What if you were in trouble? Where would you turn? In communities around the country, there is help available. Volunteers of America has been helping people build better lives for over 100 years. One of the nation's largest nonprofit charitable organizations, Volunteers of America builds stronger communities, restoring confidence and self-reliance to help people help themselves. Reaching out to abused and neglected children and families. Caring for the special needs of the elderly and disabled. Providing services to people who are homeless and in poverty. Across the nation, Volunteers of America helped over 1.5 million people last year. There are no limits to what can be done. Find out how you can help change lives in your community. Call 1-800-899-0089. Volunteers of America. There are no limits to caring.
It's not just what I get to be.
It's not just who I get to meet,
or where I get to go. Get to go! Get to go!
Just forget about being sick.
Remembering how to be a kid.
how to laugh out loud.
That anything is possible.
Leaving worry on the doorstep. Feeling 10 feet tall.
Making plans for the future.
I am still making plans for the future.
I'm still making plans for the future.
Well, maybe it would be good to dwell for a while on adolescence itself, and as we were talking at the break, what is there about adolescence that is so difficult for these kids to master? What happens in adolescence that makes kids so vulnerable, and why are so many kids having trouble during their adolescence?
Yeah. Well, I think today there's a lot more stress and pressure on kids to succeed. I think that the family is different today. There's a lot of single family, moms raising kids. Mom needs to work. She's doing the best she can. And it's important to know that mental illness is not a class or a race, or it crosses all barriers. When we were working with the suicide cluster in South Boston, one of the things we learned was that it's on a rise countrywide. They had a group of young people that were from upper class family. I think $100,000 was the average family income, and 6 or 7 kids had killed themselves in that school. And so, the drugs are readily available. I think it's significant. I think it's genetic, biological. I think that passed down from one family to another. I know a lot of the families that we worked with in South Boston had histories of depression, from grandma to mother to father, passed down, and just nobody ever dealing with that. And by the time we got down to some of the kids we work with, it's almost like they're the ones that hit the bottom with it. So I think there's a whole lot of dynamics involved. The neighborhoods are breaking up. There's no, people don't know who their neighbors are anymore. I know in the developments, there was a lot of poor families, but everybody knew each other, and every family, if there's a problem with the family, there was a grandmother there. But now with travel, the families aren't even in the same neighborhood anymore. So there's a lot of, kids are feeling left out, that latchkey generation. A lot of them go home, there's nobody there. They're 8, 9 years old. And they don't like it. They really don't. A lot of the kids, they come down, they used to come down to the collaborative and just hang out, go down to the teen centers. They needed to be around people. They don't like being home alone. So there's a lot of different things going on.
Okay, so you're suggesting that the kind of supports that maybe at one point in time were available seem to be dissolving, but let's go back to adolescence itself. Why is that a time when kids need that kind of support system?
Well, adolescents. They're going through puberty. Their hormones are raised. They're just going through all kinds of changes. They're insecure, anyways. About their bodies, about things that are going on, and they've got so many things. They're worried. It's incredible what these kids are worried about. It's just AIDS. So many things that's unbelievable. So you add that to all the psychosocial things that are going on around them, like the drugs and the alcohol.
Oh, okay.
The school issues. You have kids going to school now and shooting each other. It's just, and you wonder how much that's changed, because I grew up went to school in the 60s and 70s, and there was kids who were picked on, and that rage wasn't there, though. We get a lot of angry kids. They're very, very angry.
More, you think?
Oh, definitely. More so than we were. than we were when we were growing up.
So what are they angry about during their adolescence, would you guess?
I think a lot of opportunities aren't there that were there when we were growing up. The job opportunities. I mean, I grew up in the Irish Catholic, Dorchester, South Boston, and a lot of the union jobs were there for them. Their fathers were in them, were in the unions, and they were made available to them, and they're not there. A lot of, you know, again, I think the breakdown of the families has a lot to do with it. I really think that's a key issue. And a lot of it's, you know, people need to work today to survive, you know. Both parents need to work when there is a two-family home. So there's a lot more stressors to the kids today. The kids aren't even out playing. They're home. I watched a group of kids, and they don't want to go out and play baseball. They don't want to go out and play softball with some of the kids. They want to sit in the collaborative and play on the computer. You know, that concerns me. How they've isolated, and actually they don't get to use their brain and be creative. We used to make up a lot of games, and you know, everything was, you know, we didn't have a lot of the industrialized things available to us.
Yeah, it was nice to go out and play, and there isn't as much of that, certainly, in neighborhoods as there used to be.
No.
And do you think the inner city kids are a little afraid to go out and play, or?
Well, I don't think so. I'm sure in some areas they are. I know working with the housing development, some of the kids are afraid to go from one area to another.
Within the same development?
In the same development, because in the same areas that they live, because of that gang mentality. You know, I think a lot of the kids are they turn to the gangs for support for what they're not getting at home. And that's negative attention, but it's attention. It's a place where they've got people to support, kids to support them, and to meet those needs that they're not getting met at home. And unfortunately, there's negative consequences to that: violence and drugs and alcohol. And as we know, drugs and alcohol just medicate the problem.
So typically the gangs have a bad connotation, obviously. Are there good gangs? I mean, are there natural ways that some of these kids find support groups that don't lead them toward, you know, death and destruction?
Oh, definitely. I mean, I think kids need an adult to point them in that direction. I mean, just for instance, there's softball teams that hang out together, and I think if you grow up in an area where that's not promoted, sports and, you know, hanging on the corner is the only thing that everybody does together, that leads to trouble. I mean, growing up, I remember my dad, you know, I played softball, my brothers played football, we were all very, very active in sports and different things, and not that that's the only answer to adolescents at risk, but it definitely points you in a positive way that builds up your self-esteem. And a lot of the kids we work with don't have that. They don't have parents that attend games or sign them up for different activities. You know, even at the collaborative, there was different activities that the kids could get hooked up with. We couldn't get the parents to bring them down, and because they, for whatever was going on at home. Maybe mom was working and just couldn't do it. So I think as providers, we can, you know, need to find a way to help families get the kids more active. And we would do things as go to their home and, you know, on a day, or maybe on a Saturday, and get someone to sign that paper so the child could be hooked up with whatever activity the Teen Center is offering.
So you are suggesting that may be different from my childhood or your childhood, that there's a parallel with kids being stressed out at the same time maybe their families are stressed out.
Definitely.
Two incomes, or single parent, one income, etc.
Right. Well, and again, it crosses that economic line. You know, kids coming. It doesn't always fall back, you know, on the family. Although, you know, depression, I believe, is a family disease. I think that it does come in the family, and it's not an immoral issue. You know, just like diabetes or any other medical issue, I think that we need to take depression off a moral issue and realize that, the more we open our mind to it and deal with it, that we live in a stressful society and people do get depressed, and it's okay. It's a mental part of ourselves of as much real as the physical part of ourselves, and we need to deal with that. And that's what we try to teach the kids we work with, to talk about what's going on. And I think I talked to you, I mentioned this to you before, a lot of the kids that we were dealing with in 97, 98, we still keep in contact with them, and as issues come up, they might not have the support at home. We've gotten a few calls from those kids saying, I need to talk to someone. And I think that a lot of that was teaching the families and teaching them that when issues come up, it's okay to talk about it. And they feel comfortable doing that now. I think that's a miracle for a 17-year-old kid to call someone and say, I need to talk to you about something. I'm feeling depressed, or I'm having a hard time, this job is too stressful. That's amazing. I'm fighting with my boyfriend. I mean, I never learned how to do that. I don't think society teaches us how to do that. And I think as providers, we can, you don't have to be a provider. As a parent, you can say to your, teach your child how to do it. But you need to be open to whatever comes up, and be, because how you respond can shut that person down if you don't respond in a positive way.
Okay. So we want parents, teachers, therapists, whatever, to sort of invite kids to kind of open up. On the other hand, especially say the parents, if the kid in fact does, the parents have to be prepared.
Right, to what they're going to talk about. I mean, as a parent, they might open up and say, I'm smoking pot, I'm doing drugs, I'm feeling depressed, or my friend is doing drugs, my friend is suicidal. How you handle that is really important, and it really can lead to your child either staying open to talk to you or shutting down. So it's really important that you get the tools to deal with the different situations.
It's difficult, though, because if I put in a 12-hour day and I come home and my daughter then says, I've had a hard day today, sometimes, I must say, it may be hard for me to kind of relate to that and then kind of get beyond my own so I can get into her shoes.
Right.
You have a thought about that before the break?
Well, I think that if you don't make the time, then that's the potential for a real problem. And if your child is coming to you, which kids don't, I mean, they turn to their friends. Between the ages of 13 and 16, 17 years old, and if they're coming to you, it's a real problem. So you need to make the time. I had a foster son, and here I am working with adolescents all day, sometimes 12, 13 hours a day, and my foster son was having really serious problems. I had to make myself available to him.
It's hard.
Yeah.
Well, let's take a break, and perhaps we can pick up on that, and then maybe look a little more at, who specifically seems to be more at risk today, which group.
Okay, that's great.
Continue after the break. Thank you.
Disaster strikes and you want to help. But what happens when the tragedy is being played out on a smaller stage out of sight of reporters and television cameras? How do you know you are needed? Hello, I'm Angela Lansbury for ChildReach. In many of the world's poorest countries, poverty devastates lives with no less intensity than a hurricane or a civil war, especially the lives of children. ChildReach, one of the world's largest and most experienced sponsorship organizations, creates a continuing connection between a sponsor and a needy child overseas. This leads not only to a caring relationship, but also to family and community-based self-help programs designed to bring clean water, education, health clinics, and most of all, hope to the sponsored child and his or her family. To find out more about ChildReach, please call 800-603-1600. I'd be so grateful.
Imagine yourself serving in today's Peace Corps.
I wanted adventure. I wanted to go
out, learn about a new culture, learn a new language, and bring it back to the United States.
You know for sure for 2 years it's going to be like nothing you've ever experienced.
I joined the Peace Corps because I think Peace Corps as a development organization is one of the best in the world.
My dream of becoming a physician, if anything, has become enhanced.
The best part of my experience here, I think, as a volunteer is that I found a second family.
I think one of the best things you can do with your time, it's a great program where you can come and help people out. I'm excited about it. There's a role for you in Peace Corps. It never really feels like work. You love what you're going through. You're helping people, you're working in the community, and people really appreciate you so much for every little bitty thing that you do.
It's fun.
Make a difference. Join the Peace Corps. It's the toughest job you'll ever love.
Darlene, let's talk more specifically about who's at risk today. I mean, because obviously there seem to be some kids who sail through their adolescence with a few wrinkles, and then there are others for whom it's obviously a very difficult journey. Who are the kids who are having a very difficult journey, would you say?
Oh, I would say kids who are family history of depression or substance abuse, kids who don't have the supports that maybe their peers do, meaning family supports and neighborhood supports. Maybe kids who grow up in a high-risk area where there's a lot of drugs and violence. Also kids, I know kids who have had a suicide either in the immediate family or with a friend, have witnessed somebody, a traumatic event, or have gone through a traumatic event. So, you know, all those things put them at risk. If they've had a history of, you know, depression in their own past, you know, maybe I've lost a parent, anything like that puts a young person at risk.
So that covers a wide variety of kids.
Right.
Because,
yeah.
I mean, we really are, the intact family today is threatened. I mean,
right.
drugs and alcohol among adults is pervasive.
Right.
Stress from work. I'm sorry.
Oh, I'm sorry. Go ahead.
Yeah. No.
Well, I was just, a situation came to mind which really concerned us. We had a few suicides and quite a few in South Boston, and one of the first things we would do when we would respond is to reach out to the friends of either the victim or to the person who had tried to commit suicide, because they were definitely at risk. And there was a couple of schools in the suburban towns that we had gotten calls about from their school counselors. That were concerned about the friends of the suicide, and we weren't allowed to come into the schools to talk to anybody. The kids were never talked to. So it's definitely, if anybody from the schools are listening, the Center for Disease Control, the Department of Mental Health, there's a protocol that states that the circle of friends and family around a follow-through suicide or an attempt are very important to reach out to.
And what precluded that? I mean, what got in the way?
Well, the schools have been probably the hardest entity to get into during, both in South Boston and in around at other schools that have experienced suicides. For whatever reason, it's been a very difficult journey. The schools in South Boston have an incredible programs now in each of their schools, and that's to the credit of the principals and the providers there, that the schools outside of South Boston could use as a tool to use in their own schools.
So how do you understand that reluctance? I mean, what is that about?
I don't know what it's about. I don't know. I don't know if it's people not being educated around suicide. Most of the kids, a few of the kids from the high school that were acting out, that committed suicide and from the other schools were kids who acted out. And I think it's education. I think people don't even think about the friends, and unless you're a provider and work with people who, around suicide, I think people just weren't educated about it. And they're teachers, they're not mental health workers, and so I think education, bringing in professionals to educate both, not only the guidance counselors, but staff, the teachers, the school nurses, everybody.
But it's a little bit counterintuitive. I mean, it would seem to me every one of those teachers, principals, whomever, if asked, do you think the friends are impacted by the death, would probably say yes.
Right.
So it's a little bit hard to fully understand why then they would say no to us, an offer to let us come in and kind of at least make ourselves available to this network of friends.
Right. It's I don't know where it comes from, and I'd be guessing if I said I knew.
Yes.
Well, I think a lot of it is that we'll handle our own. It's that attitude. Mm-hmm. We'll deal with our own problems. We don't need you to come in here and help us. And I think that people have learned the hard way that that's not the right thing, the way to do it. Mm-hmm. A school on the North Shore, the guidance counselor called the Collaborative Center, and it was hooked up with the Department of Mental Health, and the school would not allow anybody to come in and talk to, there was a suicide there. Mm. And she said that the day after the suicide, 50 kids were suspended. And you wonder what was going on there. And there was a lot of acting out, obviously. Mm. And but nobody cued in to maybe there's a connection here between what happened yesterday or the week before and what they're doing today. So it's interesting. Mm. So that kids don't always tell us what's going on, by verbally. It's usually acting out. It's testing. How safe am I?
Now, drugs and alcohol enter the picture. Maybe some thoughts about how kids at risk sort of turn, why they turn to drugs and alcohol, and then maybe how the drugs and alcohol turn them.
Well, I mean, they self-medicate with drugs and alcohol. I think in the beginning it might be experimenting. They might see it going on, with their peers at home, and they pick it up. Mm-hmm. The problem is if they're high risk, that it leads to addiction. I know a lot of the kids that we were dealing with 3 years ago that were depressed and anxious. A lot of them, maybe experimented with drugs and alcohol. A lot of them now are late teens, early 20s, and dealing with heroin addiction. So there definitely is a connection there with drugs. And it's also another self-destructive behavior. And when you don't deal with mental illness, usually people acted out self-destructively, whether it be food, violence, drugs and alcohol. They just need to get the pain out. We had one girl who was in an incredible amount of pain, and she used to slash herself. And, after being in therapy, we found out that, she had a long history of sexual abuse, and also a lot of substance abuse at home. And it was just ways of screaming for help, and getting out of herself.
So you're suggesting that, these drug lords are smart because they know how, like you said earlier, and I know it to be true, that in South Boston, heroin now is a drug of choice, in part because it's become so cheap, that it's cheaper than cocaine, and it is a feel-good drug.
It's easier to get than alcohol.
Yeah.
And the sad part is we knew drugs were around in the 70s, but we didn't know very many drug dealers. Mm-hmm. Today, the 8, 9 years old they know exactly where to go to get their heroin, And not that I've seen a lot of 8, 9-year-olds, but they know where to get it. And they know where to get the drugs. It's so available, it's just incredible. And it's a lot easier to get than the alcohol.
And I think the deception is that it really does help you feel better temporarily.
It does. And it's so potent and it's so pure that they don't have to use the needle. And a lot of them are snorting it. And I've met kids, you know, I've met parents that said, you know, at least my kids are smoking pot and drinking and they're not using heroin. That's how much of a problem it is in the city. And which is scary because we all, as an addiction specialist, drugs and alcohol and pot lead to other drugs. And I've met kids who have been drunk and at a party, at peer pressure, and under the influence have tried heroin. And that's where they start to get, you know, in a lot of trouble. So, I mean, we've put 13, 14-year-old kids into detox for heroin addiction, which is very scary. And I have friends that live, you know, outside the city, and it's a city problem. It's not a city problem. You know, I've met kids from Quincy, from outside the city that come into the city to buy their drugs, you know, and, you know, it's just, it's sad. And also, you know, once, you know, they start using the drugs, where do they go for help? And
the answer is?
Well, the city of Boston just opened up a co-ed unit for adolescents. I think they have to be 12 to 18, and it's a substance abuse unit. I think there's 25 beds. But trying to get an adolescent into treatment because of the insurances is almost impossible. I mean, I've had insurance policies, providers tell me to put a 14, 15-year-old girl in an adult psychiatric unit. There's just hardly any beds in the state. And I think people need to start really opening their eyes, because I think it's touching everybody. I was talking to a family today from Canton, you know, very well-to-do family and has 2 sons. They're older, they're young men, they're in their 20s, but they're both using heroin. And they both started with drugs in their teens. And the heroin is reaching out. It's no longer that class drug or the drugs that the people that practice rhythm and blues. It's the growing drug for adolescents. It's there was an article, it's a growing drug in the colleges, along with ecstasy. Ecstasy is, I work as a psychiatric nurse in the Boston Medical Center. In the emergency room, we have kids come in all the time that in the pediatric unit on overdose on ecstasy, heroin, other drugs. So.
Well, we're going to take a break, and maybe after the break we could talk a little bit about where we go from here, and maybe spend a fair amount of time talking about the treatment options that are available. But then again, I think we also have to round that out with some discussion about post-treatment. Because, you know, if you detox somebody, then send them back to the same old stressors and the same old problems, then obviously recidivism is not hard to understand.
Exactly, yeah.
Maybe we could talk about where we go from here after the break.
Sounds great.
Welcome an exchange student into your family. Learn about another culture in a fun and exciting way with Youth for Understanding International Exchange.
I'm finding myself wanting to learn more and more about other countries, and it's really interesting.
I love learning new things and sharing my cultures.
These students bring something to the school that doesn't come from books.
While your exchange student brings their world and customs into your lives, you get to share our great country with them.
I guess I only thought you could love your own, but it's just been a great experience for all of us.
Go global. Call 1-800-TEENAGE for this free booklet. Learn how you can welcome a Youth for Understanding exchange student into your community.
We've learned so much, and very close friends of ours have now decided to host also.
I think Special Olympics
is wonderful.
It's the best thing that I've ever done in my life.
I tell my athlete, you're here because you're brave. You made it this far.
This is about the best thing that's ever happened to me because I became something I always wanted just to be a part of.
Just like a flower, it just made me blossom.
Doesn't matter if you win or lose. Just try your best.
I think we're called Special Olympics because we're special people.
I just feel a little proud of myself to reach so far.
I wanted one thing. I wanted to be an athlete. The Special Olympics gave me that opportunity.
You might can outread me, but I can outrun you.
This changed my life forever.
Changed my whole life, my whole attitude.
I have been given a special gift.
I'm happy. I'm wonderful. And I think that's great.
Well, this is our last segment. Let's talk a bit about treatment, what's available to kids, and kind of where we go from here.
Well, you know, there is hospitalization, and it depends on the issue. If a young person has a no diagnostic mental health issue, but a substance abuse problem, there is maybe 3 or 4 detoxes in the state that take adolescents.
But do you need to be detoxed? What if you got a problem, but you don't necessarily need to be detoxed?
Well, there's day programs.
Okay.
There's once a week going to counseling, and I think with adolescents and substance abuse, they need something more intensive. Mm-hmm. And it depends on the issue. Now, if we're talking about an adolescent who's smoked a couple of joints, is smoking pot, and is in the beginning of using drugs and alcohol, you know, maybe some counseling, after school program, and maybe some family counseling, because it is a family disease, and it's not just the adolescent problem. I mean, the substance abuse affects the whole family. But if you're talking about an adolescent that has a mental health issue and a substance abuse problem, you know, there's not a lot of beds, and that's been one of our worst nightmares in dealing with all because we're doing this outreach, we're getting these kids to open up, and then there's nowhere to place them. So I know in South Boston that the Department of Mental Health came forward and opened up beds in different hospitals, Charles River and Wellesley and Bournewood Hospital, and that helped us place any kid that was considered high risk. And for detox, you know, we're at the mercy of the insurance companies, unfortunately. I guess both mental health and I know down at the emergency room that they have had kids 24 hours in the emergency room trying to place them, and that's a real problem. That is a real problem. No one in a mental health crisis should have to sit in the hospital 24 hours waiting, whether it be an adult or a child, waiting to be placed. And so that's a real issue.
And what are they waiting for?
A bed to open up, or the insurance company to let us send this person to another place other than with the ones that they provide, such as the provider might only allow the adolescent or the adult to go to Bournewood, or, you know, their providers.
Their contractors.
Right, and there might be no beds open, and that's a real issue. And so it becomes a problem at the emergency room level. So we need more programs. As I said earlier, the City of Boston did open up the adolescent detox out in Long Island and Quincy, it's wonderful. And one of the biggest problems was, all right, now we get them into these programs, and a lot of them are short-term. They come back, and what happens then? And one of the things that, especially with a kid with a heroin addiction or a serious mental health issue, that they need more than that week or even a month. They need maybe a couple of months. For some, they need even more extensive care. It depends on.
You're talking about inpatient.
Inpatient.
Or residential.
Yeah. Residential. So, in South Boston, 2 grants came, one with Catholic Charities, which an aftercare program was opened up for boys, and that's a 30 to 60-day program. And the Gavin House got a grant for the state, and there's a program there, and I think it's upstairs from your office.
Right upstairs, yeah.
Yeah.
58 Old Colony Avenue.
And again, that's for boys. And my big beef is that we need more for young girls. And they equal in issues. If you talk to any mental health or substance abuse counselor or provider in South Boston and in Dorchester, they'll tell you that their referrals for girls equal that of boys. And there's not enough programs out there to place these girls. So that's.
Well, I'll ask a stupid question. Why have the boys been preferentially treated? Would you?
Well, I know with Catholic Charities that they had just opened up a young girls program out in, I think it was in Braintree, and with the Gavin House, they deal primarily with men. They have a men's halfway house, and they feel their expertise is with men, and so we need to look at that.
Now, the one on Long Island is both.
It's co-ed, which is great, but we need another.
Same facility, co-ed, or two separate?
They probably separate them. Yeah, they definitely separate them, because that creates a lot of problems when you put young adolescent boys and girls together. Day programs are wonderful. You know, after school, there's an after-school program in South Boston that is run by Andy Ward in the city of Boston City Hospital, the Boston Medical Center, and that is 3 days a week, 3 hours a day.
That's at the Collaborative?
It's out of the Collaborative Center. Yeah. So you know, there definitely has to be some follow-up. You can't. We had a lot of kids that were in crisis. They went into the hospital. They came out on medications and with different issues going on, and there was no follow-up. And follow-up is very important with them. Especially, you know, a lot of the families felt, well, the crisis is over. I don't want my kids taking this medication. And, you know, the families weren't educated around the medication. And some of the kids were on medications that concerned me because of the high risk for substance abuse. And you and I have talked about that. Coming home with medications like Klonopin and Xanax. And
that have a street value.
Well, we had 7 kids on one corner takes one of the kids Haldol, and they all went into help me, a side effect, a side effect.
Well, dystonia.
Dystonia.
Okay.
I'm sorry, that word stuck in my head.
Yeah, that's okay.
And they all ended up in the emergency room, and so they were handing the medications out, and. So we need to think about that when you're giving adolescent medications. And
now, what was that adolescent's follow-up to be?
The follow-up was...
He wasn't referred to us.
No. There actually was no follow-up. I think the family was told to get hooked up with the community health center, but the hospital did not make that referral. That needs to be done.
And quickly, too.
Yeah, it has to be done from the hospital.
Seamless, I mean, without losing a beat, so to speak.
Exactly. And what we would do is, at the Collaborative, we would do outreach to the hospitals. We work closely with Bournewood and Charles River and a few other hospitals, and we would do some outreach into the hospital and set up a collaboration. The family would sign a release giving them permission to talk to us. And so we'd know they were coming home. We'd have a phone number. And that type of extensive outreach and aftercare planning has to be done, and to make sure that the proper follow-up. And with substance abuse, sometimes it's more than just the hospitalization. They need more treatment, especially if they've done 2 and 3 hospitalizations. They're missing something.
So you were able, and I know you worked very actively and very well at the Collaborative. You were tracking these kids.
Trying to, yeah.
I mean, case managing and making sure they didn't get lost between the cracks and that referrals were picked up on.
Exactly. We did a lot of outreach with, there was a team, a clinical team, that was the Department of Mental Health, the BEST team, myself, a few other providers, and we would go into the different hospitals that our kids were ending up in, and setting up a collaboration and an affiliation agreements where if a kid from South Boston come in, we would get a call. And we'd make sure they were hooked up and the family were hooked up with services.
But if I tell you that our program in South Boston doesn't get any reimbursement to do that kind of service, that kind of outreach,
right,
would you be surprised?
No, I wouldn't be surprised. We were lucky enough to get the funding. Funding's a big problem, but it's a really important piece, the continuum of care. A few years back, I worked on a substance abuse grant, and the key goal of it was to look at case management and with the continuum of care with each patient. So we would interview them at the detox level, and there was a control group, and as case managers we'd follow them through the rehab, the detox, the rehab, and the halfway house. And it was a key issue with their sobriety and how well they did. So I think with adolescents, it goes without saying that and their families that those supports are needed.
But it goes without funding too.
You have to find the funding.
I know. Right? It's very difficult because I mean we have 2 child psychiatrists, and they would love to work more closely with the schools and in providing aftercare, etc. But there's no funding for them to do that. Dr. Mizell, for example, went to the high school. I think it was went to one of the schools. It wasn't the high school. First psychiatrist to step foot into that school in like 20 years, and nobody paid him to do that.
Right.
And yet it seems like such a easy, smart thing to do, but we really do bump into sort of funding streams and what will get paid for and what won't get paid for.
And when you think in the long run, it's such a cost-smart thing to do. Because if you can follow someone through the continuum of care, keep them in treatment, keep them hooked up with supports, you can avoid them ending up hospitalized again, or worse, ending up, in and out of treatment, which I have worked with 16, 17-year-olds who have been in treatment 11 to 15 to 20 times already.
I know. It's incredible. I mean, with Michael Dukakis, a number of us were invited to be on task forces, and we basically found out the same thing, that if you offer a continuum of care to people with chronic mental illness, in fact, the recidivism rate and tenure in the community all improved dramatically, and then the funding for those kinds of continuum of care services dries up. Right. We've got about a minute left. Are you hopeful? What are your thoughts about the future and adolescents at risk?
Well, I'm hopeful. I think that with, again, outreach, if we can get the funding, that we're starting to see the positive things that happen when you do extensive outreach and follow up with adolescents in South Boston. That when you when they start to grow, a lot of these young girls and boys we were working with are now getting in school and going on with their lives, we're not working with them. They're asking, a lot of them are calling us and saying, I need to talk, I'm having a problem. Because they trust the outreach that was given to them. That's incredible. I think that they're going to teach their children how to do that, and they're breaking a cycle. So I feel very hopeful. It's a small group of kids, but it's a start, and I think that people need to start looking at that.
All right. Well, listen, we barely scratched the surface like we knew we would.
Yeah.
But very helpful, and on behalf of the Norfolk Alliance of the Mentally Ill, I want to thank you for being here today and being a guest on Mind Over Matter. Thanks you, Darlene. For inviting me.
watching Cablevision, Channel 31, local origination programming, your hometown network.